My name is Margaret Goodrich, and I'm honored to be the moderator for this session on Master Adaptive Learners, Background and Practical Application. This developed from an objective from the SAEM Education Committee, and I'm honored to be joined by 6 esteemed colleagues who are going to help share their insights on adaptive expertise, the Master Adaptive Learner Framework, strategies for fostering these skills to become adaptive experts, and how our learning environment can potentially influence the development of these skills. Our speakers today are Dr. Michael Gisandi, Dr. Jeremy Branzetti, Dr. Linda Regan, Dr. Elspeth Pierce, Dr. Laura Hobson, and Dr. Guy Carmelli. And we ask that you please hold your questions until the end of the session. We will have some time then. And Dr. Gisandi is going to go ahead and get us kicked off.
All right. Thanks, Dr. Goodrich. And thanks to SAM for having us. We're very honored to be here. So a master adaptive learner is a theory, and we're going to get into the weeds of a theory and what supports that theory. But I wanted to just take a 30,000 foot view step back here. And what are we really talking about as you listen to our talk today? It's how we take a novice and help them become an expert. And expertise is this vague term, right? So what is expertise? We sort of have to define the term, and it has a lot of definitions that perhaps don't perfectly fit for medicine, right? You've heard about you have to play a song 10,000 times, or you need to have a requisite number of hours of practice of something. Probably the most famous operational definition of expert comes from the Dreyfus model in the business literature in the early 80s. And I think many people refer to that sort of continuum when they think about experts. But in medical education, this is sort of our version of expertise, right? We take novices, students, we prepare them to be able to see patients to a level of mastery. So for instance, if you have simulation-based mastery learning at your shop, it's a checklist of steps in a skill. We make them prepared to see a patient. They're prepared mastery. Then at the end of residency, they're safe to take care of patients. So that's minimally competent. And then over time, we hope that they develop expertise, and not all physicians do. And some of the theories is it takes a certain number of patients. It takes a certain number of clinical hours. It's still a vague term. Now, there are different types of expertise, so this maybe helps break down the definition. The first is routine expertise. So routine expertise is the ability to use your foundational knowledge to efficiently and effectively solve commonly seen problems. So problems you see every day in the emergency department, they're easy, they're almost reflexive. You can very effectively manage them. You can very efficiently manage them. You've done it a million times. It's a little bit boring. You go get your cup of coffee. So routine expertise. In contrast, there's adaptive expertise. So adaptive expertise is just a little change of words here. It's the ability to use your foundational knowledge to efficiently and effectively solve novel or never before seen problems. Unlike routine, these are the problems you've never seen. We all have one of these on every shift, right? Every single shift I see something I have not seen before. So must call on adaptive expertise skills should I have them. So these are the zebras. All right. So let me give you an example from emergency medicine I think drives this home. So we know a lot about the heart, right? Like we know the anatomy and how to read an EKG and cardiac pharmacologic agents and how to do an echo. We know a lot about it. So that's our foundational knowledge. It's deep. And we apply that knowledge application when we see atrial fibrillation. So we're taking our knowledge, we're applying it to answer a question or solve a problem. And atrial fibrillation we see every day, right? Sometimes it's slow, sometimes it's fast. Sometimes the blood pressure is high, sometimes the blood pressure is low. Still variations on the theme. It's still atrial fibrillation. But then that day when we first see Brugada syndrome, we have to integrate our knowledge. We take different parts of our conceptual understanding of the heart and its physiology, and we have to think through how to manage Brugada based upon how we've managed other somewhat similar things. There we go. Great. So if we were to take these two and combine them together, adaptive expertise is an ability to use foundational knowledge to solve problems that are routine and problems that are never seen before. So if we highlight some of these words, I think it's important as we think through the hour. It's an ability, it's a skill. Not everyone has adaptive expertise. Not everyone is an adaptive expert, but they perhaps still practice competently in emergency medicine. It doesn't mean that every physician has to be an adaptive expert. You need to use your foundational knowledge. Foundational knowledge means your book knowledge and your concept knowledge. And to very simply say from the education literature, the way that you build deep foundational knowledge is you read books. You need to efficiently and effectively problem solve. This is where day-to-day life of the ED, and then obviously the types of problems that are there. So therefore, I think, and our team thinks, that adaptive expertise is the goal of medical education. And certainly it's the goal of emergency medicine education. But we've never really said that, right? Like we've all been in medical education on this call for many years, and no one's ever said adaptive expertise is the goal. We've had many other goals, but perhaps this one is the one that encompasses conceptually all of the different tasks and competencies and et cetera that we worry so much about. This is sort of the big picture. How do we make an adaptive expert? And today we're going to talk about one theory on how adaptive experts are created or how they're trained. And that's the Master Adaptive Learner conceptual framework or theory. The MAL framework has been around since 2017. It is a hot topic. People love this topic. They talk about it in all different med conferences. It's written about all the time, including by our team. And it's a theory, right? Like maybe it's true, maybe it's not. You're going to hear this hour some of the supporting evidence for it. But simply said, the idea is that there are master adaptive learners, meaning there are learners who can adapt to their practice. And you'll see a cycle that we're going to talk about, such that they can learn more efficiently and effectively. It doesn't mean that they're the smartest kids in the class. It just means that they're the most effective learners, if you will. And there are things that these MALs do, we presume it's a theory, that allow them to eventually develop adaptive expertise. And not everyone does. So as you listen to the hour, think, was I a MAL in medical school? I don't think I was a MAL. Makes me really sad when I hear these talks. But all right, with that, I'm going to turn it over to Jeremy. He's going to take the first of the four stages, and that's phases of the MAL model. That's planning.
Thanks, Mike. Thank you, everybody. So forgive me for my little bit of raspy voice. I'm recovering from an illness now. But as you were able to see there, there's a four-stage aspect to the MAL theory. And like every cyclic model, you have to pick one to start with. But in reality, they're all interwoven, and somebody can begin their learning phase at any one of these stages. And they will then all feed off each other to then become this sort of iterative cycle that you can extrapolate from that. There's really no endpoint. It is this ongoing process. But for the sake of organization, for the sake of grounding, for the sake of simplicity, we'll start with planning as the first stage. And planning holds a special position for our team here, my colleagues like Mike and Laura and Linda, because this is the area that we've spent a number of our projects investigating. Now, when you think of planning, what comes to mind initially is a well-described or a clear set of steps or directives to go through. But in reality, if we take a look a little further, you can say we started investigating this, and most of the time for most learners, this isn't actually a well-described or well-thought-out plan. There's a lot of trial and error. There's a lot of doing things the wrong way. There's a lot of doing things the wrong way and never realizing that there's a better way, or even feeling like they have the ability to choose a better way. And if we've through sort of a high-level summary of what I think we've seen, conversely to this model where the learner is more trial and error, less organized, a little more hectic and chaotic, what we actually see from our end for the MALs is there's a little more of this organic Zen-like. It's not, I have it down perfect. Again, it's not, I have checklists and directives and exact plans for everything in more of an architect, I've drawn it all up way, but more of, I know where I go to for this. I know how I'm going to get to this. I know when I know something. I know when I don't. And it's in all sort of this internal Zen-like sense of when I need to learn and when I don't. And I think that reveals they have this implicit grasp of when, how, what, and why to learn. And it doesn't always fit into a nice, easy plan. But that being said, let's take a look at what has been both proposed for the planning stage and then what we found associated with that. So the planning stage has three associated components to be thought of that make it up. The first one is going to be gap identification, right? When you make a realization that there's something out there that I'm supposed to know, I don't know it, I need to know it, that's my gap, that easy. The next one is going to be, okay, now that I have a gap and I know I need to do something, when the heck am I going to do it? Right? The classic conundrum of the resident learner is that they are both employee and learner. So they're doing both at the same time, and there's nary time to do either. So when can they find the best opportunity to do the necessary learning to address that previous identified gap? And then lastly, you can see that there's an issue of choosing what is the resource that they're going to use, especially this day and age. We're all well aware since about a decade ago when phone first started. And while that movement, I think, has lost some steam, you can see that there's a democratization to access to resources. And as opposed to maybe 30 years ago when there was Savastin surgery and Rosen's emergency medicine, there is an unlimited amount of resources people can go to. So how do they know which one they're supposed to pick? And we, in a couple of different studies, and you'll see, we'll cite them as I go along here, I've identified some of the following behaviors associated with this. And we communicate these in a way to be able to help you see who these learners are, see these behaviors, and if you're seeing either learners do them, encourage them, reward them for that. or champion them. And if there is anything where they're struggling or they could be doing it another way, consider these behaviors that we're about to share. So let's take a look at gap identification here. The first sort of batch of learning behaviors that we learn all come from this concept of performance-driven gap identification. So performance-driven gap ID is this sense where my clinical experience dictates when I have a gap. That's kind of the simplest way to put it. You're going to hear us reference this concept of a discomfort. And this is frustratingly hard to describe because it's not well defined and it's internally, it's like asking someone about their dizziness. Like it's this just discomfort that this learner will have. They know it when they feel it. And the basic gist of this being that a learner will identify from their clinical experience, something here doesn't feel right to me. I don't feel like I've got a grasp. I feel uncomfortable about it. When we spoke to a lot of learners in a couple different studies, they would sort of reference this idea of a brick wall. They're going along at work, they're doing their thing, they're plugging along, and then bam, they hit a step where they don't have a clue what to do. And they realize like, oh, that's a gap. And that sudden moment where they're stuck and in pause and realizing I don't know what to do next is a golden opportunity for them to realize that there's something to learn. But as we as supervisors can point out to them, like, hey, remember that time when you felt stuck? That's exactly the thing to think about after shift. And maybe that's even great grounds for feedback afterwards on that shift. A lot of them will do patient follow-up. What happened the next day? What did the consultant team do? Did the surgeons agree that it's appendicitis or did they think it was something else, et cetera? And so that is one of those tasks that from a residency programmatic standpoint, we've been advocating for years, and some residents are a little more apt to doing it than others, but oftentimes they'll do it on their own in their own way, be it for documentation or just routine check-ins. And that's a really great way to trigger when they did or did not understand something. And then the last bit is really just their own curiosity, right? Something may just pique their interest and say, oh, that was cool. It could be something they want to do for a future career. If they're an EMS person and they see the EMTs did some intervention, that might make them want to go look it up, and so on and so forth. Similar to this is the second big driver of gap identification, which is going to be, we call this community driven. So this, you can make an argument that patient care is a community endeavor, sure, but these are a couple different activities here, and they're a little more on the one-on-one and less directly related to the patient. So there's a smattering of things that they'll do here. One of them, just overall, there's a group of trust that they will assemble. It's their inner circle. It's the people whose clinical acumen or ability or what they've demonstrated or their just how they want to, their role modeling is, oh, I like that. I want to be like that. I've seen the way they do this and I trust the way they do this. So those people are who they're going to go to, and they may bounce ideas, ask about a case they saw, et cetera. And I think a takeaway for all of us is if there's someone that the learner seems to really identify with or bond with, or even if you don't know, you could just ask to say, hey, is there somebody who like you really trust or feel comfortable with to run that case or to talk about or seek feedback from? And give them that little push could be really useful. The vicarious learning that they can earn from things like M&M or doing a peer review where there's no other faculty present that we saw some programs do can be great. It's a little bit of the there, but for the grace of God, go I, but also it's an opportunity to put yourself in someone else's shoes. And it really is shown that you can learn from other people's mistakes. It's not quite as potent a motivator as your own, but it is supported in psychobehavioral literature. The simple act of questioning, both directing questions outward, but also having very seemingly junior, less knowledgeable people ask you a simple question that stops you in your tracks is definitely a great way for these learners to identify, oh man, I don't know this. And that feeds back into this next point here of teaching, which is the old adage, if you know it well enough, you should be able to teach it. If they can't communicate it to someone else external to their brain, then they don't know it well enough. And to the point where really savvy mouths will intentionally go and set about trying to teach something as their sort of yardstick of like, I got it now. I was able to tell that person, it seemed to make sense. They answered my questions after I taught them. They got it. And then the last bit, the mal per learner seems far more agentic, I would say, and efficacious at seeking their own feedback. We'll get into it in a little bit later. It's not the residency program evaluation system that's particularly helpful. It's not the sort of cookie cutter guided discussions that will do it. It really is, they will go and seek out the things where they need to be better because they have a desire to, they have a recognition they could be. They're not as threatened by the idea of getting better. It's a very growth oriented perspective. So those are the gap identification behaviors that we saw. There was a lot there. But the point is, there's a lot of ways they can see where they need to learn. So let's move on next here, and we'll take a look at what isn't a gap identification thing. I wanted to highlight this at this step on purpose because these are dispelling some of the things that we think would be typical. They don't really bother with a lot of traditional goal setting practices. So you would think the SMART goals, this is what we all want learners to do. If they set goals, they'll do better. We just spoke about this with our team at ACGME, and they really don't follow this kind of goal setting practice. It's a lot more adaptable. It's a lot more take things as it comes. It's a lot more intention driven rather than specific granular goals. As I mentioned, the residency feedback system just about universally is useless to each of these learners, which is demoralizing to all of us who run programs. And I'm sure to those of us who work for accrediting bodies that make programs have feedback systems, but nevertheless, it just doesn't seem to be the big thing that drives them. So if from my end, when I remember when I was working with learners, I really try to push them to do that on their own, regardless of what the program system was. And lastly, they're really not setting goals according to the programmatic level things like milestones and EPAs, et cetera. They can try to, you can frame it to them in those ways. It just doesn't seem to be what they do. All right, so that said, pushing those aside, let's move on to where is the things for opportunities for learning. Again, two sort of big areas came out of this. The first one we'll see here is called triage. And basically, right, you get the idea. There's only so much time. They have so many things to do. They've got to pick which thing to learn. Right? There is a breadth and depth of medicine that is just overwhelming. It is a target-rich learning environment. You can't learn it all. So they've got to pick a thing that just matters to them. And they have this sort of score, internal driving system of how frequently do I see it clinically? How relevant is it to my clinical practice? Is it something I could easily address, or is this going to take forever? The second big category of ways that they'll sort of figure this out is just determining when is not only what is opportunity, but when is good enough. And I think we'll hear a little bit more about this later, but they don't aim for true competency or true mastery. It's good enough to do this point, to get through the need that I have right now for the gap that is in front of me that's preventing me from doing my work. And the end point, when they determine that something is adequate, is that discomfort I alluded to before is resolved. And again, only the learner knows that, so we can inquire about it, but we can't really see it or measure it that easily. Moving on from here, we get to the last part here, which is how do they select resources? So on one hand, there is this concept of intentional adaptation. We'll get some example to this coming up later on, and it'll be shown in a little more detail. But I wanted to bring it up here because this is where it really first starts showing up. But there is all learners essentially engage in some degree of trial and error. The master adaptive learner basically learns from the error part of their trial, and they will then start refining and curating where it is they get resources from based on what circumstance, based on what need. And it may change with training stage. Earlier on, it's more tone-like, bigger picture, foundational things. And later on, it's usually more specific article targeted to a clinical question, to a specific clinical issue. This like, what if this happens? What if this PE is hypotensive? Then what would I do? Kind of thing. And it can be an array of different things. There was no right resource, and I don't want to advocate for any one. And in fact, the savviness here, I think, is their recognition that different resources serve different purposes. And a resource can be a book, a blog, a podcast, the specific attending. It could be any sorts of thing. And then the second thing that they would do here is that they sort of curate, right? They're going to pick things based on what has done them well. There's the trust side. It served me before. I believe in this. I look at this attending. I think I know what they're doing. I believe what they're doing. They practice the way I want to practice. And then there's the, what is it now? It's a little bit of a love the one you're with, right? If it does I can't necessarily get the resource that I want. Let me get the resource that I can get right now. And if it's quick, it's in the middle of the clinical shift, I might up to date. If it's something later on when like, I don't get all these ischemic optic neuritis kind of things, I got to go dig into this deeper. They're going to be a different resource for that in that moment. All right. And so with that, we can transition out, and I'll turn it over to my next colleague for learning.
Thanks, Jeremy. So the learning phase of the master adaptive learner model is, well, where learners actually go about learning, right? So this phase is going to incorporate not just the strategies that they can utilize to both effectively learn, but the ongoing critical appraisal, as Jeremy just introduced, of the resources that they're using. So we're going to talk a little bit about both. So this is always an awkward, insightful moment where you have to sort of put under the microscope what it is that you do. So this is really that like meta moment where you're learning about learning. And so it's really a great opportunity, whether or not you're a learner or whether or not you're an educator, to better understand what are the different types of strategies that can make retention and understanding more effective. And so we're going to go over 6 evidence-based learning strategies so that no matter whether or not you're a learner or an instructor, you're going to be able to take something away directly that you can start utilizing if you've not learned about either of these 6 before, which I feel is unlikely because I think a lot of them are pretty common. So There is this great website called learningscientist.org. I take no credit for them. You can see who created them and illustrated them and funded them. And this is a fabulous site that has these 6 strategies for effective learning. They actually have printouts you can give to learners or posts that if you're a teacher, you can put in your classroom. But really, it's just a fabulous way to think about how you can structure either independently or for your learners, the experience of learning to maximize their ability to understand and retain and integrate, which is critical to the adaptive expertise mindset. So the first one is repeatable practice. And we're just going to go through these 6 really quickly and just touch base on them for just a minute so that you can walk away with a little better understanding of all 6 of them. And then we're going to go through some big picture thoughts to think about the learning phase specifically. So I think most people are familiar with this one. It's what trainees are doing when they take a test, right? Can they retrieve the information? But also it's what trainees may do when you say, okay, talk me through what you're going to do in that procedure, right? So you're forcing them to retrieve information from their brain to make sure that, one, they can retrieve it. The ability to retrieve information from nothing, right? From not a multiple choice question is truly a sign that people have that knowledge and understanding. The second is spaced practice, or you may have heard it also called spaced repetition. This is like the opposite of cramming. It's why everyone says, oh, if you're going to spend 7 hours studying tomorrow, it's just better to spend an hour studying for each of the 7 days of the week. So for those of you who plan curricula or who create a didactic material, this is why thinking about spacing out material and didactics might be helpful, because the material comes back again and forces that retrieval of the knowledge that they've already had to see what's stuck and what hasn't. This is also a great example of why longitudinal rotations are successful, right? So you spend a couple days in the PTD, you go back to the PTD next month and the month after that. And this is spacing out your repetition of seeing those patients, which really does allow for your ability to help recall and bring that back to the forefront of your mind. Number 3 is interleaving, which is a little bit more of a complex strategy that capitalizes on both retrieval practice and spaced repetition. So this strategy, you study topics or concepts in an alternating order, which allows you to, 1, both retrieve them, right? If I'm talking about A and then C and then B, and then I got to go back to C, I have to remember C in order to be able to pull it out. But also the cool thing about interleaving is that it really helps you to better understand or link how these topics relate to each other, because you're talking about them in varying order. So this is a really interesting learning strategy that I think is probably a little bit underutilized, and that we'll talk about a little bit more when we talk about elaboration. Number 4 is concrete examples. I feel like this is pretty self-explanatory. You use these all the time, whether or not you're a learner or whether or not you're a teacher. This is how you use something concrete or visible so that your learner can better understand an abstract concept. It's the reason why a medical student might remember the first patient they saw in pulmonary edema and now understand the disease process and the pathophysiology because it became real to them. They have the concrete example, whether or not it's visible or whether or not it's an example that you create for your learner with words or diagrams. 5th is dual coding. So this is a strategy that encourages 2 pathways of processing to enhance learning and retention. It can be that you perhaps have a diagram and then you also have text, right? So that's sort of what is on this slide. But if you go to the next slide, it's this concept that you're processing the way your brain works, nonverbal material, so what you look at, as well as verbal processing, so what you hear. They work in different ways, and the dual coding of those together allows for more effective retention of material in terms of your long-term memory. This is why some people like to use a concept map, or they like to draw things out, because it not just words, it allows them to use their nonverbal processing as well. And that's also the same reason why, if you go to the next slide, some people use concept maps also for something called elaboration. So elaboration is a strategy that involves thinking about something and making connections to something else. How is it similar? How is it different? So you may be like, wow, that sounds like what I do during all my shifts when I say to the resident, like, oh, okay, well, what if this patient was a pediatric patient? Or what if we were at a center that didn't have a cath lab, right? So this is how you make connections between things that are similar or different. And you can do this in multiple ways, both as an educator with a learner, but also as a learner yourself. I just mentioned on the prior slide the concept concept maps, right? So this idea of making linkages between content, you can do that yourself. And when you get to a point where you're like, I don't know why that relates to this, well, guess what? You just found a gap, and you can go back to the planning phase and decide if that's something you want to learn right now. Okay, so remember, this is the Master Adaptive Learner conceptual model, and we've gone through planning and learning, and we're going to take a second and talk about the batteries on the side. The Master Adaptive Learner model, people who put it together, Kucher and his colleagues, have these 4 batteries that they say sort of charge learning. And so curiosity, motivation, mindset, resilience. I think you would see those and say, well, of course, all of those are things that are going to charge learners to move forward and be better at the learning process. But from our work, I want to present you with 4 other ways of thinking about it. Just 4 sort of big concepts that I think if you talk to your learners about, or if as a learner you say, oh, wow, like that's really a better way to think about it, that really just makes sense and that you can really help with motivation of learning. So number 1, I think is the most obvious, make patience the center point for learning, right? For the next 4 slides, I pulled quotes from some of the work that we did, because I think that the concrete example of seeing what someone said is actually very helpful at helping you learn the material. So here, right, it's motivating. The goal for residency should be to remind people that you're responsible for the person's medical care. It also helps with the ease of retrieval, right? That idea that when you see someone, you remember that face, you remember the person who came in with that specific disease process. Big picture point number 2, learning has no endpoint, right? And I think that this idea about lifelong learning, and we all think that that's an underpinning of education, but I think that when you talk to learners, they need to recognize that learning is not a process that happens in school and residency, and then you're no longer a learner anymore. This quote, I think, is fabulous, that the best physicians we all know are the people who are learning constantly and the people who love to learn. So that this is an ongoing process that will be part of your life forever if you are going to actually be able to continually create knowledge and recreate knowledge and re-understand knowledge and integrate so that you can adapt it moving forward. Third big point, the management of emotions is crucial for learning. So we found in a number of our work, this idea that negative emotions in particular were really prominent, right? And stress makes everyone feel dumb, anxiety, stress, they make it hard for me to think. And this idea that like, actually, I'm not dumb, I'm just tired and stressed. So being able to understand what negative emotion you're experiencing, whether or not it's shame because you just said something on rounds and it was completely wrong, or inadequacy because you did a procedure in front of someone and it didn't work, or fear because you felt like someone made you feel stupid when you didn't know the answer to a question. Learning how to manage all of those emotions and figuring out how to be able to not let them stop you from moving forward, and in fact, encourage you to move forward, because I don't want to feel inadequate anymore. I want to feel like I know what I'm doing. And then this concept that successful learning requires their structure, and that this is individualized and iterative. And what does that mean? That means that everybody who is learning and every learner you work with should have something a little different about the way they do it. You need them to try something. You need them to come up with an approach and then bring that back and say, okay, well, this is how Linda does it, so I'm going to give it a try. And actually, I don't really like it, so I'm going to try how Mike does it. And oh, actually, that was a little better. Or maybe I'm going to tweak it and bring it together and do a little bit of something both they did, because that's what's going to work for me and how I learn and how I manage my emotions and what motivates me. And then the last final big picture, I think that is really important, whether or not you're a learner or whether or not you're a teacher, is that trial and error is your friend, right? The process that you use during residency to learn, during medical school to learn, during after residency to learn should change. We all know the quote about doing the same thing over and over again and expecting different results. And this ties back into what Jeremy had mentioned earlier about this idea that the most successful learners intentionally adapt the ways they are learning or the resources they're using based on location that they're physically in and the context of the learning. So here, just for a very quick example, let's say your learner's outside the hospital, right? They may, for core learning, listen to a podcast. There's a series of great podcasts on some basic material about cardiovascular topics. Or maybe they have a specific question and they're outside the hospital and they want to go and look up the actual reference, the article that is the reason why we give aspirin to everyone who comes in who's having any type of coronary event. But if they're inside the hospital, maybe they're not going to go to a journal. They're going to go to UpToDate because it's bookmarked on their computer table site, and it'll give them the quick takeaway Because when you're in the hospital, a lot of the times your learning is really more functioning as the junior resident, right? So we all know that if you have Epic or whatever electronic medical record you have, there's order sets there, right? So are you learning from that? Well, yeah, of course you are, but you're also learning how to function in the environment. So all of these areas are different ways that learners can intentionally choose to adapt where and what it is they're using to learn the material that they'll move forward to go into the next phase.
All right, so I'm going to quickly go through assessing and then adjusting. This is for assessing, this is really that trial and error stage and how learners can figure out, is their knowledge something that's becoming more solidified, or do they need to take a step back, get back into that learning phase, maybe pick a new resource to try and get that material down a little bit more. We talk about comfort, and initially learners are going to be hesitant and uncomfortable with that new knowledge. So through this phase, they're learning how to incorporate it into their practice, typically with trial and error. And the learner should be given that freedom to test out the new knowledge and potentially fail or succeed. And most of, like, if you think back to how you learn things, a lot of your learning is through failure. And so having those guardrails by mentors, by coaches, so that harm doesn't come to the patient, but the learner is still allowed to test out something new for them and potentially fail at it, can really help solidify that learning that they've done in the previous phase. So kind of thinking about how our learners are going to understand if they are comfortable with their new knowledge. Early, like medical students and residents early in training, they're going to be most familiar with getting tested on it. And so this external feedback mechanism of tests and quizzes can provide some of that feedback that they'll need in order to know if their knowledge is solidified. But it's very specific and very tailored to certain types of knowledge bases. So specifically more of that like medical knowledge, clinical knowledge stuff. Whereas we're expecting our learners to learn things that are probably not going to end up on tests. And interpersonal skills, management reasoning, teamwork, and other skills that are necessary to be a successful physician. And these aren't necessarily going to show up on their multiple choice tests. So figuring out how they're going to get that feedback is a component of this assessing phase. And so mentors and coaches should be helping learners to discover the sources of feedback and what's most applicable to what they've been learning. And then the goal in this phase, if you're trying to coach someone to be a master adaptive learner, is really to get them into that self-assessment and that having that capability so that when they're out of a structured learning environment, they're still able to keep going through the lifelong learning. For self-assessment, we tend to think of the like Dunning-Kruger effect and how learners are often thought to have poor perception of their own knowledge base. And so we typically don't rely on self-assessment as much and more rely on that external feedback mechanisms that were pointed out earlier, like the residency feedback mechanisms, milestones, in order to kind of show learners where they're at. However, the actual Dunning-Kruger curve looks like this. So for folks who are doing well, so pretty much the top half of learners understand where they're at in their capabilities and predict how they're going to perform pretty well. And the top group even underestimate their abilities a little bit. So if you're dealing with a learner who's in kind of the top half of abilities, they probably can self-assess fairly well. And so you can really rely on that in order to get them to understand where they're at in their comfort level of their new knowledge. But if you're working with a learner who might not have that ability just yet, that's where those external feedback mechanisms are going to be more important. And so within the assessing phase, feedback is going to be key. And it should be focused on the knowledge that they have just learned. So building, kind of getting to that goal setting some goals as far as how they should be getting feedback and what they should be getting feedback on should be structured around what they're trying to learn and what they're trying to get more comfortable doing. And kind of getting to the end of this phase, the learner is going to have that comfortable feel with the new knowledge that they solidified. And then that feeds into adjusting. And this, even though every phase is iterative and you can go back and forth and hop around, this is really a big branch point as far as where you can take this new knowledge. Here's really where they are starting to determine where it's applicable in context. And so we're kind of back to that adaptive expertise. And initially, they'll be able to utilize their comfortable knowledge in routine situations. And then there needs to be an understanding of how it applies in novel situations, and also adding complexity to those situations. Instead of just thinking about application of their knowledge in one patient encounter, how does it apply to a systems-based problem? And so that really happens in that adjusting phase. And then as they're working through the applicability in novel situations, is there more learning that needs to happen? Are they identifying new gaps that are coming up? And so that might push them back into that planning phase as far as building out a more bigger knowledge base in order to tackle something that's more of a systems-wide problem.
Wanted to spend a little bit of time talking about the clinical learning environment in which all of this occurs. One of the things that really struck us as our work went on is that the clinical learning environment is not always friendly, hence the slight modification to the more threatening dorsal fin of a shark that we made on some of these graphics. So the clinical learning environment really was described in 2019 in a very nice article as having really 4 dimensions, many of which overlap onto the master adaptive learner model quite nicely in terms of their impact. So the personal learning environment is a learner's individual characteristics. You have their social networks and communities, both intentional and accidental. And here is one of those areas that you're going to see teaching or instructing others as a real motivator for learning along with patient care. And then you get into sort of organizational and physical and virtual spaces in which the learning occurs. And all of these domains really have an impact on our learners and their ability to be effective learners and develop themselves. Next. So what we see is that our learners, even our mouths to some degree, and when we look at our selection criteria that our group used for our 4 studies, really our best guess is about 10 to 15% of our learners probably end up fitting this definition of mouths. And it's small. And it's not the group that necessarily that's struggling. That's another small subset. But even in this group that is achieving their goals, whether or not they hit our mouths, they are by and large overwhelmed. This is a process of going from medical student to physician who's been signed off as safe and competent for independent practice is really overwhelming. We see information overload. Our trainees are inexperienced and everything feels like a gap. They're time constrained, trying to be both learners and care providers. And that patient care responsibility often is driving everything towards care of the patient rather than development of oneself as a real effective learning physician. The other thing that we see is that our systems really are this convoluted mess of who knows what, which in many cases act against learning. We have complex systems. We're transitioning a lot. We have an electronic medical record that may prioritize from a patient safety perspective, sending things to the attending physician who has ultimate responsibility, but the trainee may not have follow-up on the critical lab results, the results of the pathology, without going through and developing extra steps. One of the things that we saw frequently in our studies is that the act of transitioning rotations, which we all do during this critical phase of learning, both in medical school and residency training, we switch clinical services, every 2, every 4 weeks at most, particularly when the individuals are early on in their training and likely on the steepest part of their learning curve. So for every single transition, now our learners have to spend a lot of time learning the hidden curriculum. What are the unwritten rules of the service that they're on? How do they interact with people? What is the appropriate exchange of information? What are their systems that they have to work in? What is the nursing culture? How do they not get overwhelmed with pages? How do they take good care of patients? And only then can they start thinking about learning the medicine. So what can we do with this? We'll come back to that in just a couple of minutes. One of the other really powerful elements in this clinical learning environment that you've already heard cited as a positive, powerful tool is the social learning environment. And what we see among our mouths is that they're intentionally developing their own learning community, both of peers as well as trusted sources. And those trusted sources may be attendings, they may be direct near peers, they may be above them in the hierarchy, they may even be below them in the medical hierarchy, but have a skill set that someone finds desirable or a powerful ability to reflect. We also see a lot of information, not necessarily from work on master adaptive learners, but looking at learning among medical students. There was a very nice study out of the Netherlands. And you know what? Simple stuff made a big difference in how effectively people learned. Things like, did people know your name? Did people have informal contact with each other and the chance to just have conversations, form relationships, discuss interesting things? And this may be one of those things that we've really lost as we transition so much to the virtual environment. And do you have longitudinal collaboration and a chance for meaningful work and engagement and investment, and therefore spiraling into your motivation there? And dovetailing with this is the importance of psychological safety, which is well demonstrated in the patient safety literature to correspond to, if people feel as though they're psychologically safe, they're more likely to speak up and intervene when they see a patient safety issue. It is correlated with a greater likelihood to ask questions for learners and a greater likelihood to engage in feedback and receiving feedback. So this is the non-punitive environment that is focused on development, that is focused on an end goal, and not on judging one's performance or judging whether or not someone should be there. People are safe to engage in the learning process. So what can we do as an educator to lean into some of these things that we've seen about in the learning environment? We can think about, how do we adapt our own instruction? In other words, using an old, well-worn mantra of diagnose the learner. How do we lean into what level our trainee is at, and work in that important zone of approximate development where you have things that are hard enough, but not so hard? We're going to want to think about, what are our foundational approaches? How do we really lean into core concepts and build that deep foundational knowledge, build core skills around, say, learning strategies that many people have never had a chance to experience in the past? We're also going to want to think about, how do we organize things so that individuals have a chance to develop that network of trusted individuals around them. Maybe it's through a formal coaching program. Maybe it's just through providing social connections and an environment in which people can form those relationships. Other things that have really come up and are making sure people have meaningful responsibility. We've seen examples of this throughout our other work. We've seen some very nicely done studies, including one that, you know what, people score higher on the USMLE if they've done more primary patient assessments. They've leaned into learning. They have that responsibility, that patient-driven motivation to engage and to find things that are exciting for them. And so keeping everything focused on the patient is one thing that we can really do as educators to make this relevant and meaningful and motivating to our learners. And then thinking about, how do we create collaboration within our community? And when we have power to do, thinking about, how can we overcome those burdens induced by a system? How do we minimize transitions? How do we make logical transitions? How do we design rotation schedules so that one rotation builds on another and we can continue to empower our learners? There was a nice study about 6-8 years ago out of University of San Francisco by Vivek Murthy that looked at the learning habits of master educators. And boy, these look a lot like what a master clinician's learner would be. And Margaret, if you'll advance the slide for me. And what do we see? We see a lot of these same behaviors. We see consistent learning efforts. We see intentional and very rigorous skill development. We see people who are curious and exploring new information, and they work in clinically rich environments. And this picture, to me, really helped round out what the long-term prognosis of a master adaptive learner can be. So just to summarize, the learning environment has incredible power to support master adaptive learners and to develop our learners in that direction, but it also has the power to be a roadblock and undermine our learners in moving forward. And I'll turn it over to Dr. Carmelli.
Thank you, everyone. I know you guys have been bearing with us for 50 minutes or so. I'm just going to spend a couple minutes here. You know, a lot of this was already touched on. I'm just going to discuss briefly those batteries that's on the left, and then some of our cognitive skills that you can see floating at the bottom of that person's silhouette there. Okay, so in the Master Adaptive Learner framework, we have a discussion of both cognitive and non-cognitive characteristics that a person may have. These here are four of the what's called non-cognitive characteristics. They're non-cognitive mainly to kind of separate them from the kind of academic skills or intelligence that someone has. And so we've kind of already discussed this earlier, but these four skills, curiosity, motivation, mindset, resilience, are just important drivers to get you to not just go through the four stages of the Master Adaptive Learner framework, but to continue doing this lifelong. I mean, adaptive expertise is another way of a form of lifelong learning. And so this is something you have to choose to do for your whole life. And so having these kind of characteristics, which I don't have to go through individually, I'm sure you know what, curiosity and motivation is, but these are important drivers that kind of help get you through it for the rest of your career. And so that's what I wanted to talk about for the personal characteristics, but we can transition now to our cognitive skills. And so, also part of the Master Adaptive Learner framework, they discuss these cognitive and metacognitive skills that you can develop and really hone in on throughout your career. And it can really go a long way into becoming adaptive expertise. I'm going to be focusing on two of the ones that were discussed a lot, on critical thinking and on reflection. Okay, so let's start by looking at critical thinking. So this is defined as the ability to apply higher order cognitive skills and the disposition to be deliberate about thinking that leads to logical and appropriate action. So in other words, evaluating information and applying it. This is not an automatic process, but rather it's deliberate. Furthermore, critical thinking isn't just about problem solving. It's an active process that challenges assumptions, weighs evidence, and applies reasoning. So basically, you need this. It informs every aspect of the Master Adaptive Learner model, all the way from identifying your own or a learner's learning needs or integrating new knowledge into clinical practice. Next, let's talk about reflection. So this is a type of metacognitive skill. So it's how we think about our own thinking. It helps us understand our own experiences. So this allows us to self-assess, recognize gaps, adjust our own learning strategies, all in order so that we can continue to grow. So for a Master Adaptive Learner, reflection helps us identify what worked, what didn't work, what we might want to change for the future. Without reflection, we risk repeating the same mistakes and failing to see opportunities for growth. So you can think of critical thinking and reflection not as one-time actions, but they create a continual learning loop that you'll hopefully do for your whole career. Every time we face a new challenge, we engage in critical thinking to evaluate the information and make decisions. Then, through reflection, we assess what we learned and how we can improve. This process reinforces habits of adaptive expertise, allowing us to continually refine our skills and approaches. Now, keep in mind, none of this occurs in a vacuum. And as we just discussed, the learning environment plays an integral part of your ability to engage in critical thinking and reflection, and even those four personal characteristics or batteries. Given how important the learning environment is, what can we do as educators to help out our students, residents, fellows to engage in habits of critical thinking and reflection? Well, there's different kind of things we could focus on. The first is we could provide targeted feedback. So it's not just like feedback on what someone did correct, but it should guide learners on analyzing their own reasoning. And so this could be done by asking why and how questions. So instead of just saying, hey, what happened there in that case, really push the learners to analyze why the situation happened that way, maybe during a debrief, and how they approached it. And similarly, it's really good to encourage self-explanation. So when learners verbalize their thought process, it strengthens their clinical reasoning. So show your work kind of thing. And often it's really helpful to kind of model this kind of reflective thinking. So, as educators, we can do what's called think aloud, where we show how we approach indecision or mistakes. Or let's say a resident comes to me with something I don't know, a new paper or a new situation. I'm very upfront about I never encountered this before. I'm not really sure about this information, but let me show you how I would approach this problem. So I have these different tools that I would look up, and this is the research question I would search for, and let's look it up together. And I kind of demonstrate the process that I would go through on my own in this think aloud. And then it could really help them develop those skills for themselves. So by fostering these habits, we help learners develop metacognitive skills necessary for adaptive expertise.
All right. And with that, we have just a few minutes for questions. I did see a couple kind of logistical questions in the chat about the slides being available and the different sources or articles mentioned, and I'd be happy to put together both a list of our resources and provide like a PDF of the slides as well. But any other questions for our presenters?
I'll throw a leading question out there.
Sure.
And this leading question might be a preview for something that if you join us in SAEM, you might get to see, which is, what do you guys think about either the evidence or lack of evidence that says that we can turn people into master adaptive learners?
I think that there's not a lot of evidence about developmental trajectory. We certainly know some people get there, but as we sort of hypothesized, it's about 10 to 15% of people who, if you ask educational experts to identify among their trainees who might fit this definition, that's about what we got pretty consistently from across multiple institutions and multiple disciplines when we were recruiting for our study. So there's a huge gap in knowing what the developmental trajectory is and what appropriate intervention or the effectiveness of any of these proposed may be. So I think that is an area that is ripe for future work.
I led with the notion that this is a conceptual framework or a theory, right? And because of that, it has no data to support it when it's initially proposed. And what's so interesting about the Mal model to me is that it like went 0 to 100, everybody loved it, everyone's talking about it, and there really was no research supporting it. And there still is very small body of literature that offers any kind of guidance as to the validity of what part's important. And anyway, I think that's always very interesting and ripe for future research is a nice way of saying that, yes.
All right. Well, in the interest of time, thank you so much to our presenters for being here and providing us some insights into the Master Adaptive Learner Model and adaptive expertise. Like I said, I'll be sure to put together a PDF and some resources for people that are interested. And thank you so much. Have a great rest of your day.